Time for another Puscast, a review of the infectious disease literature. This is covering the first 14 days in April in the year 2019. References are available at edgydoc.com, as well as links to my multimedia empire of books, blogs, podcasts, and apps. I'm emotionally exhausted from watching Tiger win the Masters, and now the Blazers are going to play the Thunder. I'm going to be a wreck by the end of the weekend. But you're not interested in that. You want to hear about the literature. So let's get to it, shall we? First up, normal body temperature. I'm always amazed when I give my sepsis lecture in the ICU how often medical students don't know what normal body temperature is, because you have to know normal body temperature before you know abnormal body temperature, i.e. what constitutes a fever. They do a lousy job of teaching vital signs in med school. So this giant meta-analysis and systematic review took all the studies they could find at looking at normal temperatures, 9,227 to be exact, and they found that the mean temperature depends, as always. It depends on the age, and it depends upon how it was measured. So if you take all the numbers together, the mean was 36.59. If it was axillary, it was 35.97, oral, 36.57, rectal, 37.04, tympanic, 36.64, and urine culture was 36.61. All these, of course, with a standard deviation of plus or minus something or other. But more importantly, or of interest, I should say, is that as you get older, your temperature falls. Contrary to what my kids would think, you do get cooler. And the elderly, i.e. those greater than age 60, me, have on average 0.23 degrees centigrade lower body temperature. So what's normal temperature? Depends on how you take it, depends on the age of your patient. And that's not even including the diurnal variation that's seen with core temperature. So normal body temperature, it depends. Different cultures have different numbers that they consider to be important or have magical significance. In medicine, those numbers tend to be 7 and 10. But once you get to 10, you might as well get to 14, which is a multiple of magic number 7. I mention this because we have 10 fingers and we have 7 days in the week, and I think those are the predominant criteria by which we give antibiotic durations. I, of course, refer you to that article on strep throat as the original sin of antibiotic duration. That being said, people just can't give short duration of antibiotics. This in English primary care, they looked at how often people stuck with the guidelines and gave short courses of antibiotics, and they didn't. What a surprise. 80% overall of antibiotic prescriptions exceeded the guidelines. This was for upper respiratory tract, acute cough, bronchitis, probably none of which need antibiotics, as well as sore throat, otitis media, acute sinusitis, the common diseases for which people get antibiotics in the outpatient setting. What we really need to shorten antibiotic duration is to basically remove a hand from every healthcare provider. If they can only count to 5, that will probably be the duration of antibiotics. But antibiotic stewardship still has a lot of work to do in the outpatient setting. There's a new drug coming down the pike I feel I should mention. Its name is maribavir. It's an anti-CMV medication, and it works by, quote, inhibition of UL97-mediated phosphorylation of nuclear lamin AC. But you probably knew that. The key thing, though, it's a different mechanism of action than ganciclovir, foscarnet, or cidofovir for treating CMV infections, and it appears to be reasonably effective and fairly non-toxic in the treatment of CMV. Evidently, it's being fast-tracked for approval, and resistant CMV isn't much of an issue in my practice, and in this era of heart, you rarely see it in HIV patients, but it is nice to have another medication in our pocket to treat that virus. In a population of solid organ transplant and bone marrow transplants with either resistant or refractory CMV, About 67% of patients responded to the medication, some at the expense of developing resistance to the medication. As we watch the measles spread across the United States, it's always nice to remind ourselves that vaccines do work, and some are quite incredible. I'm still amazed at the HPV vaccine, a vaccine that prevents cancer. This study looked at a surrogate for cancer, the development of high-grade cervical lesions over the period of 2008 to 2015. And what do you know? CIN2 plus rates fell in young women during this time. Women who are now not going to get cancer. Yay! Well, at least not HPV-related cancer. And this effect was seen in 5 different states. And note, they did not look at who was or was not vaccinated. This was just based upon how populations did with the use of the vaccine. And the population did better. Yay, go vaccines. A novel way to spread infectious diseases. This was the spread of HTLV1, and epidemiologically, it was associated with self-flagellation. Yes, cutting your back with knives or whips as part of religious practice. People still do that. These were 10 cases found in heterosexual men from Pakistan, India, and Iraq who were self-flagellating in the United Kingdom and passed on their HTLV1, as well as subsequently on a couple of them to their spouses. That was their only risk that they could ascertain for HTLV1. It looks like the knives were not kept under the most sterile technique and sometimes shared after you cut yourself. The things people do to get infectious diseases. Who gets Mycoplasma genitalium and where? This study out of Australia evaluated that question in men who have sex with men. They had 1,001. Interesting number. Why did they go to 1,001 and not stop at 1,000, which is what I would have done? Did some guy show up late and say, oh, can I join too? So they could reach 1,001? Anyway, they had 1,001 asymptomatic men who have sex with men. 95 of them had M. genitalium, of which 84% were macrolide resistant. It was most commonly found in the urethra and was associated with non-gonococcal urethritis, but not with proctitis, even though it was found in the rectum. But to me, the striking thing with these mycoplasmas is the resistance they have to our 3 main antibiotics, quinolones, tetracyclines, and in this case, 84% macrolide resistance. So group B strep is usually the disease found in diabetics or peripartum in women, but there is a unique strain of group B strep, the 283 sequence type, that has been causing invasive disease in Asia associated with eating certain freshwater fish. It's coming our way. Now they have found the same strep A galactiae, serotype 3, sequence type 283, found in tilapia fish farms in Brazil. And they suspect it was imported into Brazil from Singapore in 2014. So far, it's only causing die-off of tilapia in fish, and as they say, quote, only isolated from diseased tilapia which cannot be used for human consumption. Yeah, right. So one would hope. What's for dinner tonight, Dad? Oh, I brought home some tilapia sushi. I assume it's just a matter of time before this pathogen wanders north into U.S. fish farms. It's important to remember that dogs and cats can be an important source of plagues in human beings. There was an outbreak in Colorado where, quote, a dog was evaluated for fever and lethargy 4 days after being observed sniffing a dead prairie dog. So you let your dog out or your cat out, it has contact with a prairie dog, and the next thing you know, it has plague, and then you are exposed to plague. In this particular outbreak, no humans developed bubonic plague, but they estimate that 116 people were exposed and 46 animals. Just keep in mind that if you live in prairie dog country, that's also bubonic plague country, and when your dog or cat comes in from playing outside, autoclave them before you let them have free rein to your house. because this is nowhere near the first time that the family dog has been the source of bubonic plague. And if your dog or cat participates in self-flagellation, you got some serious problems. I can't sing for beans, so I'm not going to inflict a song upon you, but I always think of that song Tularemia, Tularulerai, whenever I see a case of tularemia. So this patient comes into the hospital with alcohol withdrawal, multi-organ system failure, and dies. They then give his organs out, and 3 people came down with Francisella tularensis. That was traced back to the organ donor. And in rooting around his house, they found several lagomorph carcasses, i.e. bunny rabbits. So the take home of the podcast this week, don't get an organ from someone sniffing a prairie dog carcass, and probably don't get an organ from someone whose yard is filled with dead rabbits. Although I doubt that is a standard question one asks before harvesting an organ. Say, got any dead rabbits outside your house? Art Linkletter's shtick was kids say the darndest things. I need to start my own show. People do the darndest things to get infections. I could do it on Animal Planet. And again, maybe I could have an autoclave company sponsor me. The range of all the infectious disease vectors is changing as the world gets hotter. One of those is the ticks that spread Lyme disease. And over the last 30 years, they've been moving north into Maine. With it has come infectious diseases. So this study looked at 230 people in Maine who had been bitten by ticks and looked for seropositivity and found that 13.9% had positive serology for Borrelia burgdorferi and 2.6 to Borrelia miyamotoi. So those particular spirochetes are moving up to Maine, and I bet they continue to go further north as the world gets hotter. It's such a bummer that the bugs that are dying off seem to be those that are pollinators, and those that suck our blood continue to thrive. And the question always comes up, how often do patients with Lyme have a co-infection? This is always postulated by the alternative Lyme world, that they have things like Babesia and Anaplasma and all sorts of other infections. I remember getting a lab report from somebody with chronic Lyme of a peripheral smear with an arrow pointing to a Babesia. Mind you, this person had never left the Willamette Valley in their life, and the arrow was pointing at an obvious platelet clump. It did not inspire me as to the rigor of that particular lab. But they looked in this study as to how many patients who were positive for Lyme had evidence of co-infections with Anaplasma, Babesia, Borrelia miyamotoi, or Powassan virus. And the answer was just a couple had evidence of Babesia, a whopping 4 of 52, but nobody else appeared to have other infectious diseases due to their Lyme disease. This is not the first study to indicate that when using appropriate testing, co-infections with Lyme, while they do occur, are the exception and not the rule, outside of the always fantasy-based practices of naturopaths and their ilk. And another spirochete that might be moving around is tick-borne relapsing fever. There were 6 cases in Apache County in the White Mountains region of Arizona. That looks like on the map it's due east of Phoenix. Historically, the cases had been in Coquino County, which is directly north of Phoenix. Maybe there are more cases being reported because there's more people in the area, and once you diagnose one case, you diagnose others since awareness goes up. But it would appear that this is a new nidus of infection for tick-borne relapsing fever in the Arizona area. It's getting to the point where you don't know where the heck any of these infections are anymore. While not classically herd immunity, it is remarkable the benefits of vaccinating children with the conjugated pneumococcal vaccine. Because when the disease disappears in the snotty-nosed vectors due to the vaccine, other people don't get invasive pneumococcal disease as well. This study looked at adults on immunosuppressive drugs and found that as a consequence of pneumococcal vaccination in children, invasive pneumococcal disease declined in both normal and immunocompetent adults. Although those on immunosuppressives still got invasive pneumococcal disease, it was with serotypes not found in the vaccine. So when kids get pneumococcal vaccination, they're also protecting chemotherapy and steroid patients from getting invasive pneumococcal disease. Now, the current guidelines suggest that if you have MRSA infections, you should keep the trough between 15 and 20, but this is not based on the best of literature. Using a retrospective study of patients with MRSA infections, they found that with 285 patients, there was no significant difference in outcomes in those who had high or low vancomycin troughs, with the one exception of a better outcome perhaps in those with pneumonia, where a higher trough was associated with better outcomes. My secret to treating MRSA infections is to find any reason I possibly can not to use vancomycin, unless I have absolutely pristine source control and a relatively trivial infection. Because we all know vancomycin stinks on ice. While there is no such thing as a strong, big gun, or powerful antibiotic, there's certainly crappy ones, and vancomycin is the archetype. There has been all this interesting data to suggest that when you combine vancomycin with a beta-lactam for MRSA, you get better outcomes. And when patients come in with sepsis or other infections where you don't know the etiology and they're sicker than stink, patients are often put on vancomycin plus Zosyn or plus cefepime. And it turns out, and I've suspected this, that if you have MRSA infections and they get vancomycin plus cefepime while you're working up their sepsis, you get better outcomes with staph infections, i.e. MRSA, than if they get vancomycin alone. And while there was no difference in mortality, patients got better faster and had less microbiologic failure if they were on vancomycin and cefepime. So another secret, if you're going to treat an MRSA infection and you don't have pristine source control and a trivial infection, is probably patients should get combination therapy for their MRSA. I'll let you pick the beta-lactam. Others than cefepime have shown this particular effect. And more data to suggest that cefazolin and nafcillin are equivalent in outcome and that cefazolin has less toxicities. One is a retrospective study of MSSA bloodstream infections and found no difference in outcomes in patients who got cefazolin or nafcillin. The other is a meta-analysis that found the same effect based on 14, again, non-randomized trials, to found that cefazolin is as good as anti-staphylococcal penicillins in the treatment of Staph aureus bloodstream infections. It keeps going back and forth, and I don't know. I keep worrying about the cephalosporin inhibition effect, where high inoculum of Staph aureus does in some cases lead to decreased efficacy of cefazolin because some anti-penicillinases from Staph aureus can kind of sort of degrade cefazolin. These tend to be clindamycin resistant. And I have had a smattering of patients who have not had pristine source control because pneumonia or an abscess in their belly that couldn't be drained, etc., who didn't do well on the cefazolin and for whatever reason finally turned around when I switched them to nafcillin. I tend to be more in favor of nafcillin when I do not have really good source control, at least up front where I can, quote, debulk, unquote, the staph infection with nafcillin, and then switch them over to cefazolin at discharge if there are psychosocial issues such as a nursing home that preclude the use of a drug like nafcillin. Like most infectious disease doctors, I overthink everything, but I'm not so certain that there isn't a subset of patients with MSSA who do better upfront on nafcillin, and those tend to be the ones I suspect that have the CIE. But I can't tell you I got great data to support that, and you know the 3 most dangerous words in medicine are, in my experience. But still, sometimes I just see a paper and go, what the... So this study comes out of a single hospital in Michigan. They looked at their Staph aureus bacteremias. They had 45 hospital-acquired Staph aureus bacteremias over a year. That's one a week. That's impressive. But even more impressive, a third of these, 16, were from peripheral IVs. Now, I see all the Staph aureus bacteremias at my hospitals, and I think I see one peripheral related staph bacteremia every 5 years. I mean, I remember writing one up on my infectious disease blog at Medscape and discussing it because it was such an anomaly in my practice. What I am shocked at is they have so many peripheral IVs associated with Staph aureus bacteremia. Either I'm not seeing all the cases, which I don't think is true because I look at every patient on antibiotics and their cultures every day, or there's something wrong in Michigan. That being said, they noted that you should not put the lines in the antecubital area and you should not leave them in for prolonged periods of time to prevent Staph aureus bacteremia. I think the third thing you can do is get admitted to a hospital in my healthcare system. I mean, geez Louise. More than one Staph aureus bacteremia from a peripheral IV a month. I'm not going to that hospital anytime soon. And if my practice was that interesting, I don't think I would do a case series and publish it. Now another, I think this makes 3, studies to show that patients on chronic suppressive antibiotics for their artificial joint infection do better than those who don't. In this particular study, they suggested that the benefit was not seen after a year of antibiotics. And this is specifically in patients who had debridement and retention of their infected prosthesis. And about 60% kept their joint with prolonged antibiotics versus 30% roughly who did not get an extended course of oral antibiotics. I don't know. Here's the deal I always think is that unlike love, staph is forever. And I had one patient, I know the 3 most dangerous words in medicine are in my experience, but I had a patient on a couple of years of suppressive therapy, and then another doctor told him he could stop it, and within 2 weeks his staph infection was back in his joint. And that's not a record. The medical literature has staph coming back up to 80 years after the initial infection. And so while the majority of patients probably do fine with just a year of oral antibiotics, the only way you know if it's going to be effective or not effective is to stop and see if the infection relapses. And if the infection relapses, the patient's up the creek. So I'm disinclined to ever stop oral suppressive antibiotics in patients who we have debrided and retained their infected joint. As always, one adverse outcome has far more power than 1,000 good outcomes. But until we have a way to know that indeed every organism in that prosthetic joint is now dead as a doornail, I would be disinclined to stop prophylactic antibiotics once I started them. One of my favorite articles is Why the Medical Literature is Wrong. It should be a must-read for anybody who's interested in the quality of medical studies. But often things are not so much wrong as overrated. This study looked back in a meta-analysis and systematic review of the effects of stool transplants on C. difficile, and they found, surprise, surprise, that they weren't as effective in randomized controlled trials as they were in open label studies. 67%, 2/3, actually not bad, were cured in randomized controlled trials versus 82.7% in the open label trials. But then that's always the case. The more rigorously you study an intervention, the less benefit it seems to have. Which is why acupuncturists and naturopaths and their ilk never want their interventions truly studied rigorously. They also note in this meta-analysis that oral or colonoscopy is a better way to get your stool transplant than an enema. And I think anytime you can avoid an enema, that would be a good thing. So it's safe to say that stool transplants work. They're just not as effective as one would like. It's very clear that all organisms are not the same. Not all E. coli are the same. This study looked at E. coli associated with ventilator-associated pneumonias in France and found that, quote, genomic and phylogenetic characteristics of E. coli pneumonia isolates from critically ill patients indicate they belong to an extraintestinal pathogenic E. coli pathovar and have distinguishable lung-specific traits. So these E. coli found in pneumonias not only have specific phylogenetic traits, they have virulence factors that make them particularly good at causing pneumonia. So if you should start seeing E. coli pneumonias in your VAPs, you may have a problem with a strain that's particularly good at causing that disease, which is both interesting and more than a little worrisome. The last thing you want in your ICU is an E. coli that has a predilection for causing pneumonia. There's been a bunch of studies out of Europe to suggest that fosfomycin is a useful drug in treating prostatitis. This is another study that confirms that. They had an interesting protocol. They gave 3 grams a day for a week and then followed 3 grams every 48 hours for the next 6 to 12 weeks. I've never understood giving loading doses for an infection when you're going to be treating it for months at a time, except to increase the cost. But they did find a good outcome with giving fosfomycin with an 82% cure rate. As I say, I've done this a couple of times, and every time I've done it so far, I have cured the prostatitis, although I have gotten into no end of arguments with insurance companies because they don't give fosfomycin for 6 to 12 weeks in this country. But I do. All right, chronic granulomatous disease. If you have a female who's a carrier, and it's an X-linked carrier, when they make their PMNs, one would expect on the basis of genetics that half the white cells would have the CGD mutation and half would be normal. But during the process of making white cells, whether that happens or not is random. And some people can have more or less CGD white cells compared to normal white cells, depending on that random variation in women who are carriers. As a result, if they have an abnormal number of abnormal white cells, even though they are carriers, they can still get the odd infections associated with chronic granulomatous disease. And the magic number is 20%. So as long as you have 20% normal cells in your mix of PMNs as a carrier, you should function normally. The take-home, though, is if you have a patient with CGD, mom's white cell function needs to be checked to see if she is at risk for infections as well, being a carrier. And a CDC report of an outbreak of coccidioidomycosis in a bunch of states, the commonality is they all went just south of Tijuana, Mexico, and Baja, California, and worked on building houses. So extend cocci country down, at least into Tijuana and Baja, California. When I was but a youngster, I considered histoplasmosis to be a Mississippi River Valley disease. Over the last couple of decades, it's clear that it's worldwide in its distribution. It can be found in the Caribbean, it can be found in India, it can be found in China, and now it is a problem in HIV in Brazil. So in thinking about histoplasmosis, it's actually worldwide in its distribution, although it does seem to have a predilection for river valleys. So when they all dry up from global warming, we won't have to worry about it anymore. You ever hear of lobomycoses? I hadn't until this week. It is not, by the way, from the immortal bounty hunter in DC Comics. Lobomycosis is due to an organism called Leucasia loboi. It's a fungus that's found in Central and South America. It occurs more in rural environments and has been found in loggers, farmers, miners, fishermen, and in this particular case report, soldiers in Colombia. What they get is multiple skin lesions, predominantly in cool areas. But here's the two take-homes from lobomycosis. 1, no one's been able to grow it yet. 2, people mistake it for leishmaniasis, so you have to look for it on the biopsy. And 3, it occurs in bottle-nosed dolphins. Treatment, surgery, itraconazole plus clofazimine plus dapsone. But the pictures in this outbreak sure do look like leishmaniasis. Maybe I had heard of lobomycosis in the past. If I did, I don't remember it. I'll try and file it away in my enfeebled memory. But I do see enough occasional cases of presumptive leishmaniasis that I do need to keep this in the back of my mind for travelers. Chagas disease, usually spread by the reduvid bug, or occasionally there have been outbreaks associated with drinking fruit juices that you puree the fruit and a reduvid bug and get Chagas that way. Now there is evidence that it's also an STD and can be spread from males to females by way of sex. There is a ton of Chagas in the southern half of the United States. It's definitely an underdiagnosed and underconsidered disease. But at least you can add Chagas to the list of all the things you can pick up having sex. And as long as we're on the topic of parasites, a study looking at treatment of Plasmodium vivax shows that 7 days of primaquine at a higher dose of 1 milligram per kilogram per day was equal to 14 days of 0.5 milligrams per kilogram per day in treating the liver phase of Plasmodium vivax. And I think we'll bring that to a close. I try and keep this to around 30 minutes, and I'm at 31:15. And the Blazers won. Yes, 1 down, 3 to go to beat the Thunder. Otherwise, this has been the Puscast, a review of the infectious disease literature covering the first 2 weeks of April in the year 2019. References, as well as links to my multimedia empire of books, blogs, podcasts, and apps, can be found at edgydoc.com. Otherwise, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Take it away, Jeff.